unfortunately. Okay, even in modern medicine, we are unable to document how many people fail to the supportive care treatment because there is a bit lack of interest, because it's not the main core domain of the care delivery, but it's an integral component of the care delivery. Okay, and that's what is important for the patient when you are talking about patient-centric care delivery. You might be curing the disease, you might be decreasing the disease burden, but you may not be having good quality of life because you are unable to deliver supportive care in a proper way. So unfortunately, I cannot show you how many drugs fail in supportive care. We don't know much. And when you talk about treatment decisions in oncology, there are different factors that come into role. What lifestyle the specific individual is following, the organ function, comorbid conditions, whether he also has other disease in addition to cancer, and then of course body size, whether it's obese, lean, and then geriatric or pediatric or woman or man, and then of course the genetic component of the tumor. So tumor cancer is like one individual or 1,000 individuals within one individual. You understand? So it's like an individual inside an individual, or 1,000 individuals inside one individual, maybe 10,000 individuals inside one individual. Why I say 10,000, 1,000 and 1 is because tumors can be homogeneous, they can have the same genetic component, they can have multiple genetic component, and it could also vary exponentially. Maybe they will have different clones of the tumor that grow in the individual. So when you are targeting these tumors, mainly in modern medicine, recently the focus is mostly moving towards the other individuals inside the individual. Okay, but we are slowly started ignoring the individual who is actually has to receive the treatment. That's what people have realized, and then slowly started considering that we should not only focus on the tumor, but we should also focus on the individual who is receiving the treatment as well. And that's what is all about the personalized medicine. And this is where Siddha medicine has a kind of a scope to collaborate with modern medicine guys to form an integrative cancer care delivery units. Just to let you know, for some of you who it's been a long time, maybe you have studied genetics. So when I talk about allele, that means there is one single variant present on a single chromosome. It could be a paternal chromosome or maternal chromosome, because we all have 23 pairs, one pair from father, one from one side from father, one side from mother. So this could be a paternal or a maternal, whatever the chromosome, and one specific locus. That means maybe chromosome 1, maybe position 100, you have this specific alphabet, A, T, G, C. Only 4 alphabets in our DNA, unlike 24 alphabets in English. So A, T, G, C. So that is called as an allele. And if you understand the constitution on both paternal and maternal chromosomes, we call it as a genotype. And if you consider the multiple variants on a single chromosome, it's a haplotype. And then diplotype is multiple loci constitutions on both paternal and maternal chromosomes is a diplotype. What about the phenotype? So the phenotype is a kind of an end product of all this genetic distribution within your genome, presented as an observable physical, biochemical and behavioral characteristic. I believe what you do in Siddha medicine, you are looking at phenotype, I believe, right? What are the criteria for you to define Vata, Pitta, Kapha? I'm asking a question because I don't know. I'm not from the domain, so I don't know. Yes. So how do you determine which component is more, which component is low, which component? Okay. So you are considering some parameter, some characteristic, biochemical observable characteristics to define the phenotype, which is possibly could be determined by the genetic makeup of an individual. Okay, that's why Ayurveda and Siddha kind of more close to the patient-centric care delivery in systems. compared to the modern medicine. When modern medicine started developing, we haven't thought about the patient-centered care delivery. But now we do realize that modern medicine also, we have to consider the patient genetic makeup. So this is a study from India only, from our study, from Dr. Tangaraj lab in Hyderabad, CCMB. They have studied different prakritis and they showed clearly that each prakriti they segregate separately when you look at the genetic status of an individual. Okay, so that means whatever prakritis that you are measuring is in fact is guided by the genetic makeup of an individual. Of course, we don't have the technology to do for everyone, but maybe if there's a good correlation between your prakritis with the genetics, then maybe you could try to implement this knowledge, information in your care delivery plans. So today my job is maybe to provide you two case examples where I would like to highlight the need in modern medicine, and it's up to you to think where you can provide help or assist the modern medicine in your best capacity to alleviate the problems or to help us to face with the problems what we currently have in modern medicine treatment. Is that sounds logical? So that I'm not here to talk about your medicine concept, I'm here to talk about what problems we currently have and where Siddha medicine can help modern medicine as well. So maybe all of you all know about what is acute lymphoblastic leukemia. Okay, so it's rapidly growing lymphoblasts, unmatured in the circulation. Okay, it's a hematological cancer, and it mostly happens in children. The most widely seen cancers in children is ALL. So good news is that it's curable in modern medicine. You can cure it. Okay, 90% of the people can be cured in the West. Only 50 to 60% in our country and other developing countries have developed LMICs. But the problem is the treatment protocol is quite longer. So the treatment protocol includes like induction, consolidation, and then maintenance. So induction and consolidation can happen within the hospital setup where there is a stringent environment where everybody can guide, everyday nurse can visit, everyday physician can see. But maintenance, it happens in their homes. They have to go back to their home and then they have to take the medication. So one of the problems with this medication is you are using chemotherapy. Obviously it will not kill all rapidly developing cells. So that means they are at risk of myelosuppression as well. It's going to kill the cells that are going to fight the infections. And you think about a scenario when I will give this example which happened within the hospital setup. Then we will think about what will be the scenario when it happens in the maintenance phase. So in this child, this guy was given the standard care, but there was a pancytopenia when this medication was given. So all the cells were low. Then the physician has stopped the chemotherapy because that is the cause for having the pancytopenia. But still, the symptoms persisted. It has not recovered because whatever the damage was to be caused by the chemotherapy has already caused. And then the guy is no more because the disease has not killed the child, but the treatment has killed the child. Okay, so this is where one can look at why only this specific child had this problem, why not the other. Okay, if 10 people are receiving, maybe 2 or 3 will go through this kind of process or this kind of problems. Maybe 8 other, they don't have this kind of problems. So why only this specific child has this problem? Then if you look at the metabolism, I don't want to go through the details, it's a bit complex. Just remember that if he cannot metabolize the drug which is toxic, it's going to cause more problem. And if he's unable to recover from the problem caused by the drug, he's going to have the problem. So these are the 2 possible causes why the child has more problem. So there are some genetic variants that predisposes this child to have more problem with the specific drug that is given during the consolidation phase, which is 6-mercaptopurine. These are the genetic variants we know. So now what to do if you have this experience, what you will do next time when you see similar patient or when a patient comes for ALL treatment, maybe you will do genotype for these 2 specific genes and you see these specific variants are present or absent, and then accordingly you can adjust the dose. so that you don't have a problem of pancytopenia and you don't also have the problem of not stopping the treatment as well, so that you get a benefit of both. And some physicians are under concern, which we still don't know, is that if you reduce the dose in this individual to prevent the pancytopenia, maybe the effect of leukemia could be compromised. So is there any way that you don't want to compromise on the effect, but you still want to avoid the pancytopenia effect of this chemotherapy? Maybe there is some other approach that you can use to prevent this pancytopenia. Maybe that is where Siddha medicine can help, for example. Kind of a prophylactic dietary component or some component that can increase the adaptive response or increase the immunity of an individual. Not via lymphoblast, by other myeloid cells. So you need to think about that action. So there is a possibility of integrative approach of combining with other modalities of treatment in this specific scenario. And that's what we also found in JIPMER as well, that the people who are carrying this specific variant, for example, if 14 were carrying, 12 of them had a severe problem, myelosuppression, when they are at home during the maintenance phase. This is the case when the patients were receiving treatment at home. So you all know about the microbiological infections, how they exponentially grow, right? So if there's a myelosuppression, by the time if the person is away 300 kilometers or 400 kilometers away from the cancer care center, by the time he comes, he's at risk of losing life, okay? Because it can turn into sepsis and then collapse, organ damage, etc. So to prevent all that, maybe what you could do is you could use the genetic information of individual at the beginning of the treatment itself, segregate them, that this person is at risk of developing problem, this person may be at least less risk of developing problem, and this person may be not having the risk of developing problem. And then try to test the alternative modalities, okay? Modern modality is only reducing the dose, okay? Why not trying the alternate modality along with dose modification, okay? So this is something that has to be tested scientifically, and then you need to provide evidence scientifically so that people can start using those kind of strategies. Is that clear? So that is one of the problems that we currently have in modern medicine, that we are trying to deal right now with understanding the genetic makeup and then adjust the doses of the molecules or stop the treatment for a few days so that you recover and then you start again. So to avoid all this chaos, is there any way that you can take every day some little prophylactic medication which will not affect the chemotherapy? It should not affect the chemotherapy, it should not interact with the chemotherapy, but it should help the patient to fight with the infections. I will not go into these details. Another case I will talk about is stem cell transplantation setting, okay? So most of these patients who receive chemotherapy for ALL, most of them, as I said, can be cured. Some of them, they cannot be cured, of course. Not all the 100% efficacy would be there for any treatment modality. So around 10 to 15% they will not be cured. So there is other modalities to collect the good cells from other individual and put it in the individual who is having the bad cells in his circulation. But before you put the good cells, you get rid of the bad cells by using chemotherapy again. So here also the problem is the same. Chemotherapy you are giving to kill the bad cells, disease cells, and then you take fresh cells from other individuals and put it into the individual. And it's a very expensive affair. Okay, so that means you are putting a lot of resources into the system to get rid of the problem, that is the disease. Of course, any treatment modality also comes with certain problems in modern medicine. So these are the list of the problems that we see in this specific setup. Okay. So hemorrhagic cystitis, maybe you all know bladder cystitis, and then sinusoidal obstruction syndrome, which happens in the liver, vasculature of the liver, and then most importantly AGVHD. So there previously we talked about infections. Okay, we need cells that can kill infections. Here AGVHD, actually we are taking cells from other individual and putting in the deceased individual so that the other patient's T cells immune cells, considers these recipient cells as foreign and start attacking the tissues. So here this is a $1 million question. Here we need a medication that can prevent this reaction, that can specifically kill T cells. Okay, that can be given as a prophylactic management for AGV-HD. So this is a $1 million question. If you have any remedy in your Siddha medicine that you would like to try, there are animal models that you could test for AGV-HD, and then you can proof of concept can be developed. Okay, and you can become a billionaire in overnight if you have a clear remedy. Of course, maybe you not, because it's not patented, it's a traditional knowledge. So and then other treatment related mortality and relapse, of course, they are the common problems that comes with any package of treatment. Now the question is, can we also identify these individuals who are at risk of having these complications, and then try to use some approaches. Approaches can be from the modern medicine, approaches can be from traditional medicine. I will give you one example of traditional medicine which is being used here as a treatment, and which is the company has made billions with that specific modality. So I will talk about the modality, the problem SOS, sinusoidal obstruction syndrome. The sinusoidal space in liver, they get blocked, and then there will be increase in the size of the liver, there is a palpitation, weight gain, and then the fluid accumulation everywhere, and it can kill the patient. Okay, so that is the sinusoidal obstruction syndrome. So this is the chemotherapy that we use to kill the bad cells in the recipient before you infuse the normal cells. So as you could see, on the x-axis there is an increasing intensity, and the y-axis increasing toxicity. So these combinations, they are having more problems than these combinations, but these combinations are less efficacious than these combinations. So you need to find a balance between these combinations, which is still a question in modern medicine. We still do trial and error for this specific setup, for HSCT setup. So to cut short all these investigations, yes, here there is a possibility of identifying the people who are at risk of developing toxicity by looking at the genetic makeup. Okay, you have identified that the person is at risk of having toxicity. What next? You cannot stop the treatment, because that is the only cure available for the patients who cannot be cured by the normal chemotherapy regimens. So we need to do the stem cell transplantation. That is the final cure. Okay. Then maybe you should think of, maybe you could use other modalities, other strategies to prevent toxicities in high risk individuals. Okay, maybe use some prophylactic medication, use some prophylactic strategy in those medications. One of them could be dose reduction of the molecule which is actually causing the problem. Is that clear? Because that molecule, when it is present in very high concentration, that can kill, especially this molecule called bisulfan, which is an alkylating agent, that can kill the patient. So you try to reduce the dose so that you try to achieve the optimal efficacy, but at the same time you don't lose its, you will not have its toxicity, because at beyond certain level it will cause the toxicity. Am I making sense? We are all on the same page, or I'm just blobbering something? I want to be more communicative. I don't want to tell what I know, but I wanted to tell what you could actually grasp and then take home with you to your thoughts. So basically what you can do is, to prevent this problem, you can take the genetic material of individual and you can screen, and you can define high risk, low risk, medium risk, whatsoever. So what if it is a high risk? We still don't have a clear solution. Okay. But in Italy, on the streets, they used to sell a traditional, I cannot say medicine or meat, whatever. So this comes from pig intestine. Pig's intestine, they scrape some material of the intestine, and they used to sell on kilos for nothing, for 20 cents, 30 cents, And one company called Jazz Pharmaceuticals, they have tested this molecule for SOS, for that material. It's a kind of a protein, comes from pig intestine, okay, fragmented, which is called D-fibrotide. And now we can use that as a prophylaxis for SOS. It helps 70% of the people who are given prophylaxis can be, saved, not for not having the specific problem. So that works. The defibrotide, which is being sold on the streets, now it's being patented and it's been sold for one dose is 100,000 Swiss francs. That means 100,000 into 100 in Indian rupees. So that is one dose of the defibrotide that they are selling for this stem cell transplant guys. Of course, in our country we don't have access to it because it's very expensive medication. So that's the message that I would like to pass. I would not like to go through all these details. The take-home message is that in modern message we still have greater success rates, but at the same time we also have certain problems that we have to deal with. Okay, and these are the ones, maybe your possibilities to help and to integrate with modern medicine to see how you can help to avoid these problems or to protect the patients for not having these kind of problems. But at the same time, those strategies should not interfere with the main modality of the treatment. That is something that we have to keep in our mind when we think of such strategies. Sorry, you have something to say?
Nothing.
Okay. So, and then there is another medication. You all know capecitabine. Have you heard about this molecule, capecitabine? Yeah. So this is another case. People were afraid to use this molecule in the past because many people died because of diarrhea. It's a very strange thing to hear, right? People dying of diarrhea is unacceptable in the modern days, isn't it? But yes, people have died because of that when they use chemotherapy, capecitabine, and also some liver toxicity also is caused by these specific molecules. So how to prevent that? So in modern medicine we have found a patient-centric way of looking at genetic material, that is DPYD testing, okay, which is the molecule that metabolizes the capecitabine molecule. So if the person cannot metabolize capecitabine well, he is at risk of having more problems. Like any other examples that we have seen until now, ALL, mycoptopurine, stem cell transplantation, busulfan, SYS, liver problem, DPYD, again diarrhea and liver problem when patients are receiving capecitabine. And capecitabine is the most widely used molecule in palliative care setup. Okay, and it is coming with a lot of problems. It comes with some hand-foot syndrome, it comes with some diarrhea, nausea, whatsoever. Most of the chemotherapy molecules, they all come with diarrhea, nausea. This is the common problems that you foresee with any of these molecules. And that is where you can also, the other strategies, other preventive strategies, because in modern medicine also we do have supportive care medication. But the problem of using supportive care medication is there are a lot of interactions, drug-drug interactions with the main modality of the treatment. Then we are afraid to which one to use, which one to not to use. Okay. And it's very difficult to monitor if there is a clear drug-drug interaction exists. And sometimes you are forced to use the medication for the main modality of the treatment by dividing or by deleting the supportive care medication from the regimen because they have some interactions. We don't want to compromise on the efficacy of the medication, right? So in that case, maybe you have a scope, provided, as I mentioned, you should not interact with the main modality of the treatment and the evidence has to be properly generated. Okay, I know several studies they have done on gingiber. I don't know, gingiber is a component of Siddha medicine or not, I'm not aware of. I honestly accept that I'm not from your domain. But yeah, people are trying some alternative Ayurvedic preparations also for nausea and vomiting in cancer chemotherapy. And I mentioned an example of AGVHD, right, for stem cell transplantation. People are also trying some Ayurvedic medications called Vithania somnifera extracts, etc. So they have tried that in animal models, and they are also planning to do some preclinical studies. So it all comes from scientific way of progressing from in vitro to preclinical to the clinical stage, rather than straight away going into the. So you need to spend some time and resource as well as one person cannot do everything. So you need to form a team. Maybe some have the skill of the in vitro, some have the skill of preclinical, some have the skill of clinical. So you need to have a little consortiums and like-minded people to work on the specific problem, and then only you will make a lot of strides and progress, which has happened in modern medicine because of only that for simple reason. Okay, so with that, I think we discussed most of the messages. Maybe we can have a little interactive questions and answers rather than me talking from our work. What I have presented is our work actually, that AGVHD and SOS and then myelosuppression, Luther-15, TPMT work. We also have an ongoing prospective cohort study where we are collecting around 500 children from South India and North India, and we are genetically screening, and then we are looking for toxicity risk relation with the genetics. So if someone wants some information, some cohort details, some statistics, some information, we are happy to share if that can help you to design your own research. Okay. And what you can do in Siddha medicine. So in modern medicine we have the main modality of the treatment, we have the measure to detect who is at risk of having problems with the main modality of the treatment. Then Siddha medicine, what you can offer. Maybe this is what you can offer from Siddha medicine. For example, for the people who are not able to fight the infections, maybe you need to have some adjuvant treatment that can help them to improve their immunity. Maybe liver toxicities, maybe you can have some prophylactic medication that can prevent these liver problems that could be seen with chemotherapy molecules. But provided you should generate evidence in a proper way, measuring longitudinally when you give prophylactic medication, whether the liver functions is quite normal or abnormal. Because most of the times from the modern medicine, the claims comes is that we don't have a standard way of delivering the preparations and formulations. There is no clear evidence or longitudinal evidence on the follow-up laboratory and biochemical parameters data when we use other strategies of medicine. And that is where you have to, I think, focus and try to include stringent follow-up criteria in your research design. Okay. And of course, GI protective effect, that is also something that you could focus upon. And in addition to the topical treatments is something that you could also focus in your domain. So in future, maybe this could be the way. You have already one OPD, palliative care OPD, inaugurated this month. So that's a good start actually. So actually other places also should be aware of that. And it has to work in harmony and in collaboration, and it has to be in integration. Okay. So because it's a small gathering, I don't know, we are going live also. Live, it's being recorded. Okay. Maybe off the record, the main problem with care delivery, clinical care delivery, in the past how it was done is, it was individual-centric care delivery. Okay, but now things have changed. It's a team-centric care delivery, and it's more and more of objectified care delivery. So that means an young doctor coming to the practice and a 50 years experience doctor who is in the practice can be brought to the same level of care delivery when they deliver the care, because the knowledge is available, information is available elsewhere, everywhere. Okay, thanks to AI, thanks to several other tools that are currently available, that brings in all that experience to the young graduate. Okay, so that means these people can think about what they should start thinking about what we really don't know, than simply practicing what we already know, because the knowledge level, everything is, he will not even gain the experience to reach that level. When they graduated, they are already at that level, more or less, because you have the tools with you. The tools can change the practice. So the integration, that's what we foresee, is that the patient can be diagnosed with the disease, the problem. If it is a palliative care, obviously he's going to go for palliative care, but before that maybe you could do kind of little genotyping to see the risk of problems that he could encounter. And then you define the risk stratification, and in your plan, you can give the choice for the patient whether to continue with the modern care delivery itself, or he would like to opt for other strategies, other modalities, if that's the patient choice. Because we also have the right to choose the treatment what we want, either to choose or decline. Okay, that's the patient right. And then they can go to the integrated care delivery. It could be Siddha, it could be Ayurveda, or it could be homeopathic, or it could be nothing as well. And you should not leave there. That is where the most problems comes in all integrated care deliveries. These guys think that they will take care. Those guys think that they will take care. So the integration is like you have to work in harmony. So these guys should know what the guys have planned. Those guys should know what these guys have planned. And patients should be on the same page that these both are same team. They are not different teams. Then the care delivery can happen more appropriately. So for that you need a clear monitoring, and then feedback loop has to be in place. And then only that integrated care delivery can happen. I hope I am clear. It's more of a philosophical thought in the end that I am projecting here, not more of a science, but that's how things work in science as well. So with that, I think I would not like to go into the details. So my suggestion would be, so the Siddha adjuvant therapy in alignment with pharmacogenomics, that is genetics, that we consider to identify the risk, we can use to prevent the toxicities, some of the strategies that you can think. And we can also try to optimize the dose. That means reduced toxicity is mainly focused upon only alleviating the toxicities. Whereas the strategies of optimized dosing, sometimes when you want to reduce the dose because it's causing toxicity, you are also compromising on the efficacy. So on that part, maybe you can think that maybe you can, there may be a strategy I'm not aware of, you are the domain experts. Maybe there may be a strategy where you don't want to compromise on the metabolic capacity, but you want to prevent the problem that is happening in the individual. And in the end, in palliative care, I think this is what is most important. You must also try to include in your research design, if it is a clinical, for example, the patient-centric outcomes, the participation of the patient, like quality of life questionnaire. And these questionnaires is something that we don't have to reinvent the wheel. There are several questionnaires that have been validated, available in several languages, that you can consider to use for your own research. Maybe the scales are developed for modern medicine, it doesn't matter. The purpose is the same in the end. And obviously, we wanted to avoid hospitalizations because of the problems. The person coming from maintenance therapy from home, because of the sepsis to a hospital, has to stay in the hospital for 10 days. It's a big expense. When I'm saying big expense, even at the level of JIPMER, it's a big expense because money is not coming for free. All the doctors were paid salary, all the nurses, all the medication, everything is a taxpayer's money. Everything is the money. So there is a lot of resources that are being used because of the toxicities also that we encounter in cancer chemotherapy as well as in palliative care. So that is where you can also contribute to limit the usage of this kind of resources. And at the same time, you must also take the opportunity of your clinic to provide awareness on available modern medicine opportunities for them to receive. Okay, because modern medicine also has thrived quite a lot. Every day it is growing exponentially. 10 years ago, lung cancer patient, we say 20% survival or 30% survival. Now, today, we can say that 60% of the people can be survived. 40% survival difference in 10 years. It's a quite tremendous amount of progress. Of course, there are two things. Survival, that increasing lifespan and increasing health span. Okay, so whether the quality of life is also good or not in that case. Maybe that is where you should focus also as well to help your modern medicine colleagues. Along with the lifespan, you are also increasing the health span without compromising the efficacy of the modern medical treatment. Okay, with that, these are the messages I think everybody has already talked about. And one most important thing maybe I would like to focus is here, this data repositories. How it works in modern medicine is that we do have a lot of data repositories, whatever the data that we generate, like clinical record registry, and then genetic data registry, proteomics data registry, metabolomics data, whatever data that we generate, it's all registered. It's not only registered, repository, but it should be accessible. It has to be findable, it has to be accessible, and it has to be interoperable. Okay, so if I want to change some data to something else, it has to have some metadata that to tell that okay, this is from what, how to use this, and then reusable. Okay, your colleague is working on some topical treatment for hand-foot syndrome in one clinic. Another colleague, without knowing each other, they also worked in another clinic. Maybe you should come together, collaborate. Maybe you are not collaborating earlier, you have completed the study, but the data generated should be able to interoperable and combine and reusable. Then you can generate more evidence. So maybe you don't have the good number of samples when you design the study. Maybe that person did the same study, maybe he had additional number of samples that could satisfy the sample size in the end for statistical significance. So this is how you should have your planning. Maybe data repositories is something that we in our country also we are not more pro for transparently documenting our activities, including lab activities, etc., unless otherwise it's a patient care report. Okay, research reports, we usually lab notebooks and the data generated from the laboratory, it's not much stringent. Maybe that is where you could also make stride, and then you can clearly say that okay, this is what we have achieved and this is what we do, this is how we do, and then people will eventually they have no way to say no, because every process is more transparent, accurate, and they can also access what it is, what you have done through your research project. And with that, I thank my current department hosting me in JIPMAR Medical Oncology, and I thank you for patient listening. And this is my past team at University of Geneva, where I lived for 14 years of my life, and I'm back here to India last year. And these are my funding agencies who are helping and who are going to help in our future research projects. If you have any questions, and I'm happy to answer.
Recent days, you using Ayush medicine as a supportive drug or management or a immune booster?
I'm not at the forefront of the clinical care delivery, but what I can say is that patient may be going and using. Maybe the patient is by himself, sorry?
Patient is integrating.
Yeah, patient is by himself, maybe is integrating, but the modern medicine care delivery guys are also not against using this, provided there is a clear evidence. That's what I'm trying to emphasize again and again, is that we should not use it just because it exists. We should use it provided we have a clear convincement of the people. So that's what I would like to emphasize. Also, any other questions or? Okay, then.
Excuse me, sir. It's a nice session and a very insightful session. Just I want to confirm that though there any integration in plan, it is available so far. Integration already there is an integration available in the GMS center, sir, for oncology.
I'm not aware of that, madam.
Okay, sir. Okay, sir. And the palliative, while you are planning the palliative care and the toxicity reduction, you just go through the standardized dose regimens according to the weight, or something else based on the phenotype or the genotype based dose determination was there, sir.
Okay. So when it comes to care delivery palliative setup for toxicity problems, the global trend is in the West mostly. For example, DPYD testing is an example that I can give here, is that you do DPYD testing, that is also FDA recommended recently on the label, and then you adjust the doses of the capecitabine. But most of the centers may not have this possibility of testing for DPYD genetic variants. So what they can do is they can start with a lower dose and see if there is any problem, intolerance whatsoever, and then they can slowly increase the dose. So that is another modality that people are using in palliative care. But in curative setting, it could be different. Curative setting, when you are asked to implement the guided practice, you are liable to implement the guided practice. So if you are not testing, and if you are using the lower dose first and then slowly incrementing, maybe you are denying the therapeutic benefit from the beginning at a standard dose. So maybe the curative intent also for prophylactic strategies also could have, you guys can also think what could be prevented in that curative setup as well as along with the palliative setup. Palliative setup is okay, but still, even if you use the strategy of starting with lower dose and then increasing also, maybe you are not offering benefit when you use the lower dose. So it's actually just something that is put into the system for no use. That is my thoughts on that.
During the curative regimen, do there any inter-between checking of the toxicity of particular organs?
That happens regularly at every cycle. That is what the follow-up is very important. The monitoring, whenever you receive chemotherapy, the monitoring of the laboratory, biochemical, behavioral, and every characteristics, including disease characteristics from time to time, is essential. That's an integral part of the protocol delivery. Yeah.
During such screening, we can easily come across the pancytopenia that should be easily early detected and can be prevented, sir. Even with the sources also, we are able to miss few cases.
Yes, true.
Here I want to suggest some of the non-pharmacological intervention like Varnam therapies, which are proactive in helping the bone marrow suppression prevention measures. That some points are mentioned specifically for the bone marrow reactivation and energization. Through that, we can enhance the production of blood cells that can be retried, sir. If any possibility arises, we are ready to join with you, sir. Just for non-pharmacological intervention.
Yes, madam. So that is in your hands. The ball is in your hands. So you should devise a protocol clearly, what exactly you want to answer, and approach our RCC center, and people will be happy to lend hands to work together. That is one thing. And then since you mentioned about the comprehensive programs, non-treatment programs, another domain of where you have the possibility is the survivorship clinics. We talked about palliative care delivery, that is fine. But people are cured of cancer. Okay, they don't have the disease, but still have a lot of other problems. Okay, that could be easily dealt by other strategies, in addition to the modern medicine strategies. And that is where I think you also can take part, because the burden on modern medicine is too much. There are few physicians, a lot of patients. So if you can also take care of these survivorship clinics without affecting the main modality of the disease care, I think that would be kind of a more integrative approach as well with the survivorship clinics. For example, you may have some topical, some marma, you said, some pain management, etc. And I'm not aware of your domain, sorry for my ignorance, but yeah, that is where you can have more possibilities as well in
Thank you,
survivorship
sir.
clinics.
Thank you, sir.
Thank you.
Thank you, sir. Thank you for such a wonderful presentation. Sir, please. So, 1 minute, sir. So now I would like to invite Dr. Sathirajeshwaran, sir, ED in charge of our institute, to honor our today's speaker.
the details of the presentation because it's too much.
Thank you, sir. I would like to kindly inform you, you all please assemble the lower stairs for a group photo. Please.
இது ஏன் சார் போடுறீங்க இந்த டைம் இருக்குல்ல ஸ்க்ரீனிங் டைம் இல்லாத டைமில் இது போட்டுருக்கீங்க இது ஆஃப் பண்ணால் திருப்பி கூடுதல்
என்னோட யூஜி வந்து பாளையங்கோட்டை 2002 பேட்ச், பிஜி என்ஐஎஸ் பீடியாட்ரிக்ஸ் வந்து 2007 to 11 பேட்ச். தேங்க்யூ. கடலூர், என்னோட நேட்டிவ் வந்து கடலூர் தான். தேங்க்யூ.
ஐ எம் டாக்டர் வி வித்யாபதி. யூஜி வந்து சாய்ராம் 2010, பிஜி வந்து நேஷனல் இன்ஸ்டியூட் ஜென்ரல் மெடிசன். அப்புறம் 3 years ஏடிஎஸ் சித்தா மெடிக்கல் காலேஜில் ஒர்க் பண்ணேன். அதுக்கப்புறமா இப்போ கவர்மெண்ட் ஜிஹெச் விக்ரவாண்டியில் ஒர்க் பண்ணேன் ப்ரிஃபரன்ஸ்.
My name is A. Sindaswamy.
Sorry. Sir, why are you preparing this CME? Actually, DSM நாமே பண்ணிட்டாங்க. அதுக்கு ஆன்சர் சொல்லலாம். ஆனா we need that answer. வித்யா பத்தி சொல்லாம உட்கார்ந்து நீ அவன் ஏட்டாரா?
My name is A. Sindaswamy, Assistant Medical Officer, Government Medical College and Hospital, Kallakurichi. UG PG 2013 பாஸ் அவுட்டு, சென்னை மெடிக்கல் சித்தா மெடிக்கல் காலேஜ். தேங்க்யூ.
கேன்சர் ரிலேட்டடாக மருந்து தயாரிப்பு சொன்னாங்க. அதை சொன்னாங்கன்னா லாவண்யா இனி வந்து
நான் நிறையா சித்த மருந்து
standalone treatment and integrative treatment, and also in palliative care, and also in prevention stage from the recurrence. So I'm sharing some of the cases here, and also the hurdles which we are facing in preclinical studies, that is also we shared in these slides. So next. So first we have to know what is integrative and palliative care. So integration that means that not only between the two systems, that is mainstream system and complementary systems, that it should be also within the systems. So in integration in means of first the clinicians இப்போ நிறைய பேர் டிஸ்கஸ் பண்ணல. Some are good in doing medicines, and some are good in diagnosis, and some are good in counseling the patients, and some are good in the doing external therapies. So first integration should start between us. So then only we can integrate with the other system. So clinicians should integrate within ourselves, then with the researchers. So as sir said, we should develop a protocol. So for developing a protocol or a proper guidelines, we need evidence. So that too from the clinical aspect. So as a case series or case reports or something. So clinicians should help or should give the reports and publish it in a very good journal with high impact to create evidence, so that we can proceed for other guidelines. So then the findings from the clinicians and the researchers should be incorporated into the curriculum, so that the faculty members will teach the students about the current happenings in the clinics as well as in the research aspect. So the integration should start from within our system between the clinicians, researchers and the academic institutions. So then palliative care, traditionally we know that palliative care is about the end of life care. So before decades, so it was only about the end of life care. After having all the possible treatments for a particular disease, so at the hospice only they will have palliative care. So after some years, the palliative care has been changed to the best supportive care. So when the treatment stops and there is no hope for the curative treatment, they will prefer for the palliative care. So then it has been evaluated as the yearly palliative care once the disease is diagnosed as a non-curable disease, so such as cancer. So along with the mainstream medicine, that is curative, that is given with the main aim for curation. Along with that, to improve the quality of life of the patient and for the symptomatic management, palliative care is given along with the mainstream curative medicines. So then now what does palliative care is really mean is, so survivorship integration. So beyond treating and managing the symptoms of the patient, we should also take care of the caregivers of the patient. So providing counseling about their mental health and supporting their family in financial aspect. So everything should be taken into consideration when it comes to the palliative care. So since our mainstream system is there to provide us the standard guidelines, with the standard guidelines they are providing curative, in the name of curative treatment, they are providing some treatment for the cancer. But still there is a need for Siddha to integrate or participate in this cancer. So அதில் பார்க்கும்போது, ஸோ யூஸ் ஆஃப் காம்ப்ளிமெண்ட்ரி அண்ட் ஆல்டர்னேட்டிவ் மெடிசன், கேன்சர் பேஷண்ட்ஸில் எத்தனை பேர் காம்ப்ளிமெண்ட்ரி அண்ட் ஆல்டர்னேட்டிவ் மெடிசன்ஸை எதிர்பார்க்குறாங்க, ஆர் ஒன்ஸ் தே ஆர் டயக்னோஸ்ட் அஸ் கேன்சர், அஸ் தே ஆர் ஹேவிங் கேன்சர், அவங்க வந்து ரியலி டைரெக்டாக வந்து அலோபதி மெடிசன்ஸ்க்கு தான் போகிறாங்களா, ஆர் அவங்களுக்கு ட்ரெடிஷ்னலாக ஃபாலோ ஆகிட்டு வரக்கூடிய காம்ப்ளிமெண்ட்ரி மெடிசன் ஆர் அவங்களோட ட்ரெடிஷ்னல் மெடிசனை ஃபாலோ பண்ணுறாங்களான்னு சொல்லி, இது நார்த் இந்தியாவில் சப் ஹிமாலயன் ஸ்டேட்டில் நடந்த ஒரு ஸ்டடி. திஸ் ஸ்டடி வாஸ் carried out by the questionnaire based survey in an allopathy hospital. So அவங்க வந்து ஒரு 2600 cases எடுத்து சர்வே பண்ணி பார்க்கும்போது, ஸோ அதில் வந்து 40 to 60% of patients during their initial stage when they are diagnosed as cancer, அவங்க வந்து அவங்களோட காம்ப்ளிமெண்ட்ரி ஆர் ட்ரெடிஷ்னல் மெடிசனை தான் வந்து போய் பார்த்துருக்காங்க. அதில் 58.9% ஆஃப் பேஷண்ட்ஸ் இனிஷியல் ஸ்டேஜில் வித் தட் காம்ப்ளிமெண்டரி அண்ட் ஆல்டர்னேட்டிவ் மெடிசன் they have benefited from that complementary medicine in their initial stage. After that only they have reported to the modern mainstream hospitals. So this is about the North India. So what is the status in South India? So that too in Chennai. So this study was image was taken from our article published as morbidity profile of cancer patients attending Siddha's Cancer Special OPD of Arindaranna Government Hospital. So here I highlighted only the patient's treatment history. So based on the patient treatment history, I have made this pie chart. So in this 44% of the patients who attended the Siddha Cancer Care Hospital is with no history of previous treatments. So remaining 56% of patients were already taken the conventional treatment and revisited our OPD for adjourned care. So use of complementary and alternative medicine is widespread among cancer patients in India and Tamil Nadu. So we have to work on this area. So what is eminence and evidence? So eminence is about the trust on the experts. So we trust our seniors or we trust our literature evidence like that. So முன்னாடி ஒரு பேஷண்ட்க்கு ஏதோ ஒரு மெடிசன் கொடுத்து அவங்க வந்து க்யூர் ஆகிருக்கலாம், அதை வந்து நமக்கு ஏதோ ஒரு சீனியர் சொல்லலாம். ஸோ அதே மாதிரி ஒரு பேஷண்ட் வரும்போது நான் வந்து கொடுக்கலாம். அது மாதிரி வந்து ஆனால் நான் வந்து அவங்க எத்தனை பேஷண்ட் பார்த்தாங்க, அதில் எத்தனை வந்து ஒர்க் அவுட் ஆச்சுன்னு தெரியாது. ஸோ அந்த நம்பர்ஸை வச்சு சொல்கிறது தான் எவிடன்ஸ். ஸோ வி ஹாவ் டு கிரியேட் மோர் எவிடன்ஸ். ஸோ இத்தனை பேஷண்ட்ஸ் பார்த்தா அதில் இத்தனை பேருக்கு மெடிசன் கொடுத்தா இத்தனை பேருக்கு வந்து சரியாச்சு சரியாகல. ஸோ ஸ்டாட்டிஸ்டிக்கலி சிக்னிஃபிகண்ட்டாக இருக்கா இல்லையான்றத ரிசல்ட் வந்து டேட்டா பேசிஸில் கொடுக்குறது தான் எவிடன்ஸ். ஸோ இது ரெண்டுத்தையுமே நம்ம வந்து வி ஹாவ் டு டேக் பேலன்ஸ் பிட்வீன் போத் த எமினன்ஸ் அண்ட் த எவிடன்ஸ் டு in the aspect of cancer care. So evidence refined by eminence, refined by evidence, guided by ethics and centered to the patient. So literature, so as many literatures are there which indicates the medicines for cancer. So in various terms such as putru, vipurudi, kirandi, kadalai and many terms, durmangisa valarsi, durmamism, like that. So we have collected literatures and made a book called A Compendium of Siddha Medicines for Cancer, Volume 1, and it was published by Indian Medicine of Homeopathy, Indian Medicine and Homeopathy Department. So this book contains 203 medicine preparations. Among them 180 internal and 23 internal medicines were described. So with the over medicine adanoda reference oda kuduthirukkom with the page number of the original literature. And among the 32 internal medicines, we 180 internal medicines, like 30 types of internal medicines are included in this book. And while coming to the terms of the cancer, we were able to find out 50 types of cancer, including Besi Putru, Idar Putru, Talir Putru, like terms. So different types of terms, Sandhu Putru. So in the Marina, Kabala Putru also we had a medicine indicated for Kabala Putru. So also with this medicines from literatures, we also included the experience of 5 medical practitioners as well, 5 medical practitioners who is vigorously practicing, concentrating on cancer. So with these medicines, how many of the medicines is clinically or pre-clinically proved? So we have the eminence, so we have to create evidence. So how many medicines are being evidenced with from this question mark? So what are the hurdles we are having in preclinical studies? அப்படினு பார்த்தா first வந்து solubility issues. So when we are so இப்போ நான் வந்து ப்ரீக்ளினிக்கல் ஸ்டடீஸில் நான் ஹேண்டில் பண்ணுறது போது தான் எனக்கு தெரியுது. ஸோ ஒவ்வொரு மெடிசனுமே கீ பேஸ்டு மெடிசனாக இருந்தாலும் சரி, லேகியமாக இருந்தாலும் சரி, அது வந்து நம்ம ஒரு சால்வெண்ட், ஸ்டாண்டர்டான சால்வெண்ட் செல் கல்ச்சருக்கு யூஸ் பண்ணக்கூடியது. அந்த செல்லுக்கும் அந்த சால்வெண்ட்னால வயபிலிட்டி இஷ்யூஸ் வரக்கூடாது. பட் அந்த சேம் டைம் நம்ம மெடிசனும் அதில் சால்யூபிள் ஆகணும் அப்படின்னா அது வந்து நம்ம சால்வெண்ட் சால்வெண்ட் வந்து நம்ம அப்ராப்ரியேட்டாக சூஸ் பண்ணுறதுலேயும் ஒரு டிஃபிகல்ட்டிஸ் இருக்குது. தென் வந்து அதே நம்ம சால்வெண்ட் வந்து எடுத்தாலுமே அது வந்து ஃபுல்லாக சாலிபிள் ஆகாது. நம்ம மெடிசன்ஸ் எப்பவுமே டிஸ்பர்ஸ்டாக இருக்கும். ஸோ அந்த டிஸ்பர்ஸ் ஆகிறத நம்ம எப்படி கொடுக்கணும் அப்படின்னா அது வந்து 24 hours நம்ம செல்லுக்கு ட்ரீட் பண்ண போகிறோம் அப்படின்னா அதை வந்து 24 hours முன்னாடி நம்ம செல்லுக்கு ட்ரீட் பண்ணுறதுக்கு முன்னாடியே சாலிபிளைஸ் பண்ணி டிஸ்பர்ஸ் சால்வெண்ட் கூட மிக்ஸ் பண்ணி வச்சு பார்த்து அது வந்து செட்டில் ஆகுதா இல்லையான்றதை நம்ம பார்க்கணும். ஸோ அது ஒன்ஸ் செட்டில் ஆகுது அப்படின்னா 24 hours அது செட்டில் ஆகுதுன்னா 24 hours ட்ரீட்மெண்ட்டில் அதுக்குள்ளேயே செட்டில் ஆகுற மாதிரி இருந்துச்சுன்னா இட் வில் நாட் ரியாக்ட் வித் த செல்ஸ் அண்ட் இட் வில் நாட் என்டர் இன் டு த செல்ஸ் அண்ட் தேர் வில் பி நோ ரியாக்ஷன் பிகாஸ் ஆஃப் த drug we are testing. So we should check that, and when I